Can everybody see my screen okay?
Yes.
And then how's the volume? Can you hear me okay as well?
Yeah, I think it's all good. I think we can hear you well. So, inshallah, I guess we'll make a start now. So, we're really pleased to have Dr. Amer again from last week. He did the lecture on ATLS and anesthetics, and we're now going to be focusing on the secondary survey of ATLS. So, a bit of an introduction. Dr. Amer is the Associate Trauma Medical Director and Director of Emergency and General Surgery at St. Vincent Mercy Hospital in Toledo, and he's giving our second lecture. So yeah, Jazakallah khair. Thank you so much for your time, Dr. Amr, and you take it away.
Good morning, everybody. Thank you, Yumna, for the introduction, and thank you for having me. It's really an honor to be here. For those of you in Gaza, you know, our my thoughts and prayers are with you every day. Hopefully, wherever you guys are, you guys can get some benefit from this lecture and learn something. So last week, we talked about the primary survey. So this is the second part of this lecture series, which is about the secondary survey. And this is all part of the initial assessment and the management. What I'd like to do is start by reviewing some of the primary survey again, just to solidify some of those concepts. And then we'll move on to the secondary survey and talk about what that is. So again, preparation means if you're at the trauma center, at the ER, or the field hospital, or wherever you are, if you have an idea of what's about to arrive, like what patient's coming, preparation is always good if you can do that. So you think, what's my team members? Like, who do I have on my team? What are their capabilities? What supplies do I have? Let's say if somebody had a chest trauma, like a crush injury to the chest, do you have material or supplies to intubate that patient? Do you have chest tube supplies? Things like that. So if you have the opportunity to prepare, and you don't always have that opportunity, but if you have that opportunity, preparation is very important because you'll instead when the you can have things ready because when the patient gets to your trauma center, no matter where this trauma center is, a lot of times it becomes very chaotic. And so if you're trying to find things, it becomes very difficult. So then that's preparation. Primary survey we'll review again, but this is the first thing you do for the patient when they arrive. That's the A, B, C, D, E. And then there's resuscitation and adjuncts to the primary survey. Then you reevaluate the patient before moving on to your detailed secondary survey, which is really what we'll talk about today and add that to our knowledge. And reevaluation and adjuncts, again, you want to do afterward. And then before you send this patient for the definitive care, whether that be transfer to another hospital, whether that be to the operating room, whether it's to the ICU, you want to reevaluate everything. Just make sure the patient's doing okay before you transition them. It's always reevaluation is always there before a transition of care. So before you move from one phase to the next, you want to just quickly reevaluate. And these things take minutes, like they don't take very long. Just a quick eyeball of the patient from head to toe before you move on. So again, we talked about this last week, but what's a quick and simple way to assess a patient in 10 seconds? Can anybody tell me? All right, so a quick and easy way to assess a patient in 10 seconds would be to ask the patient his or her name and ask the patient what happened. Because if they're able to tell you what their name is and what happened, that basically tells you an appropriate response confirms that their airway's patent, they're able to move air in and out and speak. They have sufficient air reserve to permit speech. Let's say somebody has like severe shortness of breath, they're not going to be able to phonate and talk, right? They also says that the brain is functioning. So they're getting good perfusion to the brain that they're able to speak. And also D, disability, they have a clear sensorium. These basically, just those two questions will tell you most of the primary survey very quickly. And so again, the primary survey, you have airway with C-spine protection. So just checking the airway, making sure they're maintaining an airway, that they don't need to be intubated or don't need anything else. Breathing represents listening to the breath sounds, making sure that their chest wall is rising, that there's no injury or sucking chest wound or anything like that to the chest. Circulation with hemorrhage control. So you want to stop exsanguinating hemorrhage, tourniquets or pressure. You want to get access, IV access on the patient. You want to check blood pressure. You want to check pulses. This all falls, again, under circulation. Disability we talked about is like the quick neuro status of the patient, which we discussed was quick objective way was calculating a GCS on the patient, which is the Glasgow Coma Scale. And exposure would be like kind of expose the patient quickly to make sure we're not missing any injuries. And environmental control would be like if they have chemicals on them, you want to wash it off, or if they're cold, you want to warm them, put warm blankets, cover them so they don't become hypothermic. This slide basically reviews most of what we talked about last week with regards to what the primary survey is and what it entails. But again, when resuscitation, when you're resuscitating a patient, you want to protect and secure your airways, whether it be if they're breathing on their own and they're securing their airway, or if they need to be intubated. You want to make sure they're ventilating properly, they're oxygenating properly. So if you have a pulse oximeter, you want to hook them up to the pulse ox, see what their saturation is. If there's bleeding, again, you want to stop the bleeding because if they have continued bleeding and you're not controlling it, this is a big deal, right? They're not going to survive most likely. And then you begin blood resuscitation, minimal crystalloids. You don't want to overdo the crystalloids, but you move on to volume resuscitation. And then protecting the patient from hypothermia is always part of resuscitation because, as we know, if somebody's hypothermic, that's not good for their overall well-being and their coagulopathy. It can cause coagulopathy. So when we say like the lethal triad, classically, we're talking about acidosis, hypothermia, and coagulopathy. Once those three things happen, it's very hard to get the patient back. We did talk about the adjuncts to the primary survey. So these are things you do after the primary survey is done that can kind of give you some more information. And you do these before you move on to the secondary survey. So, you get vital signs. If they're intubated, you need a arterial blood gas and you have access to it. You can get ABGs. Like I said, you put them on the pulse oximeter or end-tidal CO2. If they're intubated, and this is severe trauma, you're probably going to need a Foley catheter, an orogastric tube also to decompress the stomach, checking the urine output, getting an EKG. These are all things that can be done after the primary survey, as well as some basic imaging, right? So we talked about, let's say you intubate a patient or you're concerned about chest wall trauma. We talked about getting a chest x-ray right after, or a pelvis x-ray if you're worried about pelvic trauma. If the patient's stable and you have access to a CT scanner, sometimes we skip this step. We just go straight to the CT scanner after we're done with our primary and secondary survey because let's say they're stable, they're breathing fine. I'm not suspecting a big pelvic injury that I need to put a pelvic binder on right away. I'm not suspecting a big pneumothorax. Then once I'm done with my initial assessment, which again is a primary and secondary survey, and I know I'm going to get a CT scan, I just send the patient to CT scan so I'm not getting extra x-rays. But let's say you don't have access to a CT scanner, this is when you'd want to get the x-rays to kind of give yourself some more information. So if you get a chest x-ray and a pelvis x-ray and you do a fast, that basically covers the vast majority of where the patient's going to have major issues with regards to bleeding, right? If the chest x-ray will cover your chest, the fast will cover the intra-abdominal area, the abdomen basically, and the pelvis X-ray covers the pelvis. So then all you have to do is check the extremities and check the neuro exam. If you do that, you don't need a CT scanner, and you've basically covered the entire body. So yeah, we talked about the fast. That's part of the imaging that you can do at the bedside during the primary survey. We kind of went through the components of the fast last time. And then, at the end of the primary survey, you want to consider early transfer. So if you're in a field hospital or you're in a hospital that has very limited resources or does not have surgeons or whatever the case may be, you want to get things ready for the patient to be transferred. So if you need to make a phone call, you need to start that process. You want to get that process started early so that there's no delay when you can actually transfer the patient. So that kind of recaps the primary survey. So we'll move on to the secondary survey. The secondary survey is basically a complete history and physical of the patient. And this isn't something that takes a long time. The whole thing should take 5 minutes because you're just very quickly doing a head to toe exam. The point here is you're looking for injuries that are obvious and or areas that the patient's very tender in that you're concerned about an injury that you may want to get imaging. So it's not something that's like very detailed like you would do maybe in like a medicine office or a primary care office. This is like quick, very basic. You're just trying to find what's injured on this patient, right? Because you have to move on to the next thing. You don't want to waste time. So I would say, 5 minutes for this secondary survey should be more than enough. And so again, when do I start the secondary survey? After the primary survey is complete, after your A, B, C, D, E's are done, and you've reassessed them and you know you're good, then you move on to the primary survey. Let's say you want to make sure your vital signs are you're not unstable, right? Let's say somebody's in hemorrhagic shock, they're hypotensive. You don't want to go on to a head to toe examination when you should be worried about, we need to massively transfuse this patient. I need to find out what exactly is going on. Let's say the patient's crashing, they need to be, and it's an abdominal wound. The patient may need, massive transfusion and sent immediately to the operating room. So if your vital functions are normal and returning to normal, then, obviously that's when you do the secondary survey. So the components of a secondary survey is a history. So talking to the patient, seeing what their history is, and also the history of the trauma. Physical exam, which is a head to toe examination, doing a neurologic exam. When we say complete, this is complete in the terms of like a trauma neuro exam, not a neurologist's neuro exam. So it's not going to be very involved. And then figuring out if you need any special diagnostic tests, and then again, always reevaluation. When we talk about a trauma, in a perfect world, ideally, it's done by a team. It's not one person doing everything. So you have a team you're splitting the responsibilities of who's doing what. This, in times of war or obviously the situation in Gaza, it's very difficult to have a team like this because of the resource problems, the staffing problems, obviously the chaos of the whole situation. But just for your information, like this is what you want in a perfect world. This is what you want. You want to have someone who's dedicated for the airway. That's usually an emergency physician, and that person can do airway, can make sure your cervical spine is good. The person can help with procedures, but really, like at my hospital, the emergency physician, they're responsible for airway, and then they talk to the patient so they can get the history while we're working. Respiratory therapist, someone that can help with the ventilators. You want to have like a nurse on each side that can get vital signs, that can put the patient on the monitor, that can get IV access. Obviously, if the patient needs a central line, then a physician will have to do a central line. And then, at least two physicians that are, in the United States, the trauma surgery team, it will be surgeons. So you have the attending surgeon, a trauma surgeon who's kind of telling people what to do, is running the trauma. And then usually a resident will do the primary and secondary survey, if any procedures, and then a fast exam. And sometimes you have a pharmacist that's available, and then a nurse is documenting everything. So this is how like a large trauma center in the United States is typically how the team that runs the trauma. But you may not have that, so you have to adjust or to your capabilities and work with the environment you're in. But so some of the concepts, if you keep them in mind, hopefully as long as you're doing something from you're quickly running through the primary survey, secondary survey, even if you're by yourself, that's good enough. So when we talk about history, the first step, um, the history, there's a mnemonic we call it's ample. So this is what you have to do basically. Just quickly get what allergies the patient has, what medications they're on, their past medical history, last time they ate, and then events of what happened or how the mechanism of the trauma. So that if the patient's unconscious and they can't give you this history, you're not going to know this, right? Like let's say the patient got intubated, you're not going to be able to get a history. So um, it is what it is. But if the patient's awake and they're talking, you want to try to get this history. If the patient's not awake, let's say, but their family members with them, you can get the history from the family member. Um, medications, if somebody's on blood thinners, if they're on a beta blocker, this type of information can be helpful because it's going to change the clinical picture, right? If they're on blood thinners, this is going to make them bleed more. For example, if they're on beta blocker, that may mask tachycardia. So your patient's vitals may not be very telling of what the clinical situation is. And then past medical history, obviously, if you want to know pregnancy status, when they ate last, especially if they may be getting emergency procedures. And then events, obviously, just figuring out what exactly happened. So just remember ample. This is kind of the quick way to do a history. We usually do this, towards the end of the secondary survey, or you can get it in the beginning if you have someone, that's dedicated to it. Mechanism of injury is very important in a trauma. So you want to know what happened because if somebody was in a explosion and there's burns, uh, that patient's going to be much different than a patient that was in a car crash that flipped over. You have to get some type of history so you can tell what your index of suspicion is going to be for what type of injury. Let's say somebody was a fall, and that's the only thing you were told. A fall from ground level fall, like someone fell from tripped over a cat, is different than someone who fell out of a second story building, right? So that's the mechanism is very important. Sometimes also the mechanism is important to kind of quickly tell you, like, how am I gonna work up this patient? If you're in a mass casualty situation and you know that there's multiple traumas and the mechanism was very severe, let's say a bus crash or a huge blast, you're not going to have time to do head to toe on everybody. So then the mechanism is bad. If you have to figure out a way to quickly triage these patients. Also, if let's say you have access to a CT scanner and you know the mechanism is very high, you may want to just get full CTs on all these patients, right? Chest, abdomen, pelvis, head, neck, everything. We call that a pan scan or a pan CT, right? Because you don't want to waste time and the mechanism is very severe and you don't want to miss injuries. So you have to adapt to the situation. The mechanism of injury, the more information you can get, the better, because that'll tell you like how concerned should you be. And then going into the head to toe now, we'll just quickly kind of talk about the components of the head to toe examination. Like I said, this isn't a very detailed exam like you would do in a nice office where you have all the time in the world. You're just kind of quickly doing a head to toe exam so you can catch injuries. So for the head, we say you look at the head, you expose the head, see if there's any lacerations or anything like that. A scalp laceration, somebody can bleed to death from it. If it's missed and you're not seeing it, you have to see the whole head because the scalp is very well perfused. And if a large laceration of the scalp, some people can have significant bleeding from that. So a quick external exam, want to palpate the scalp. You can sometimes feel for a skull fracture with good palpation. Comprehensive eye and ear exam, just basically if the patient's awake, can you see, follow my finger, put a light in the eye, check for pupillary response and pupillary reflex, looking inside the ear. That's all. That's all you have to do. Looking at the ear and looking inside. If you have an otoscope, that's enough. Visual acuity, if they're awake, obviously you can do that quickly. But like I said, you're not wasting too much time with this. If they're unconscious, you're not going to be able to do a lot of these neurologic things. So that's going to limit your exam, obviously. So if they're unconscious and you're suspecting a head injury, this patient needs to get a CT scan of their head at some point. That's what they need. When we say maxillofacial, so basically you look at the face, you want to feel for any fractures, you want to look for any deformities, malocclusion. If they're awake, you can have them open and shut their jaw and see if they have any pain with that. That'll kind of clue you into maybe a jaw fracture or some type of injury. Look inside the mouth. The neck, this is something you want to be very wary about because the mechanism is very important. If somebody has a blunt injury to the neck, it's different than if somebody has a penetrating injury. A penetrating injury, you really have to look out for hard signs of injury. So, like if they have pulsatile bleeding or a very expanding hematoma, you need to catch that very quickly because this patient may need to go quickly to the operating room to get control of that bleeding. When we talk about blunt injury, let's say like this may be a blunt injury that they hit a cable or maybe a seat belt or something. You want to worry about blunt injury to the vessels. You want to worry about the cervical spine fracture. So there's different considerations. But if you see any obvious injury to the neck, you need to be very concerned because the neck obviously there's significant vasculature, right? The carotids, the internal jugular, there's the airway. So there's vascular concerns and there's airway concerns. So you really have to have a very high index of suspicion. If you see any signs of trauma like this at the neck, you want to get imaging. You want to make sure the patient's securing their airway. Um, some things you want to look out for, like I said, is a hematoma. If you feel crepitus, that could be like an airway injury or a pneumothorax even. Stridor, if you hear stridor, then that should clue you in to concerns about the airway. So just be very careful with the neck, right? You don't want to miss any neck injuries. And then things can change too. So they may look fine 1 minute, and then later on they may uh, uh, lose their airway. So let's say you saw someone, they had a hematoma, they were protecting their airway, things looked okay, but that they have some concern, and let's say you move on to the next patient, just keep in the back of your head that this patient, if any issues happen, I need to act on it quickly, or I need to reevaluate this patient. When we talk about the chest, inspect the chest, look for any signs of injury. You want to palpate. So if they have bad fractures, sometimes you'll be able to feel rib fractures. You'll be able to feel sometimes crepitus if there's rib fractures associated with pneumothorax, let's say. Percussion, we don't really do, but auscultation would be just listening with a stethoscope, listening to the breath sounds. And then, like we said, the adjunct to the primary survey. If you haven't done it, maybe get an x-ray, chest x-ray. As I explained, if somebody's like stable, I'm not very worried, but I know they were in a big mechanism of trauma and they have some bruising, but let's say they're breathing fine. If I'm gonna CT that patient and I know I'm gonna CT them and they don't have to get an x-ray, I'll skip the x-ray and I'll just send them to CT scan if there's no, because I don't want to delay things. You don't want to waste x-rays. You don't want to waste time. So if I know I'm going to get a CT scan and they're doing okay, I'll just get the CT scan. Let's say I'm concerned about rib fractures or whatnot. Well, if you examine the patient, you listen, they're having trouble breathing. Let's say you're not hearing breath sounds on one side, and they're not crashing, but you're concerned about a pneumothorax. In that case, I'd get an X-ray because then quickly you can see if you're able to do it portable, especially like have the X-ray person come to you. You can see if there's a pneumothorax before you go anywhere, and then you can put a chest tube in, for example. If you don't hear breath sounds, and they're crashing, you don't want to wait for an X-ray. You just put the chest tube. This is like stuff that's going to happen during the primary survey. So for abdomen, again, you inspect. We don't auscultate the abdomen. The bowel sounds don't really matter, but you just press on the belly, check for distension. You're checking for pain and tenderness, bruising. if somebody has a huge bruise, like they were in a bad car crash and they were wearing a seatbelt, they had a huge bruise across the abdomen, we call that a seatbelt sign. That's very concerning for bowel injury inside the abdomen. Some of the things you want to be careful with the abdomen is a CT scanner is not going to tell you if there's hollow viscous injury very well, like if there's a tear in the small bowel. But something, it'll give you hints. So there may be some fluid on the CT scanner, or the mesentery looks injured. Then you know this patient needs to go to the operating room. But other than those things, for hollow viscous injury, you need to um, just keep a high index of suspicion. You want to keep reevaluating the patient. And if they're peritoneal, like they have peritonitis, or they're very tender, they have rigidity, they have rebound tenderness, these things should make you concerned that, hey, there's something going on in the abdomen. We may need to go to the operating room, or whatever you need to do. But that's basically it. And mostly it's going to be inspection and palpation. And then, obviously perineum, you just want to look at these things. You want to look for any contusions in the perineum, hematomas, lacerations, any blood at the urethra. The rectum, we don't always do a rectal tone, but if you're concerned about a spinal cord injury or a severe pelvic fracture, you should probably do a rectal exam. Make sure there's no bleeding or blood. Make sure if you're worried about a spinal cord injury, make sure that they have rectal tone. And then the vagina, obviously, is just looking for external injuries. The pelvis, so you want to compress the pelvis laterally and anteriorly because you're looking for pain. If you're also looking for instability. If you're pressing on the pelvis and you feel it crunching, or when you push down, you feel it moving, that's an unstable pelvis. So you need to do something about that, because people can bleed to death from pelvic fractures. So if somebody has a unstable pelvic fracture, like you're pressing laterally and it feels like it's crunching in, they may have an open book pelvic fracture. This patient may need a pelvic binder, just a sheet around the pelvis to close that space so they don't bleed to death from their pelvis. And if you're not sure, and you can just get a quick X-ray and you can see, this X-ray is basically showing bilateral pubic rami fractures here. But the space, the ring of the pelvis appears to be closed, so it's not an open book. There's not a huge open book component to this fracture, so you're not as worried with like severe bleeding. There may be like a shear injury here, but an open book pelvic fracture where this symphysis is separated, you need to close that with a pelvic binder, because if you don't, they're at risk for significant hemorrhage. Another thing that can clue you into pelvic fracture or acetabular fracture is if the leg length, their legs are not equal, and that can tell you that there may be a fracture somewhere. And we talked about instability, and then getting X-rays as needed. You want to avoid excessive pelvic manipulation because that can exacerbate bleeding, and then don't underestimate pelvic blood loss. You can bleed to death from the pelvis. There's no question about that. With regards to the extremities, you just kind of quickly examine everything. We just kind of go head to arms. We press on the arms. We look for any deformities or fractures, pain. You look at the arm perfusion. If a limb is like blue or mottled or cold, then you're worried about a vascular injury. If you haven't checked pulses under C of the primary survey, then you want to make sure you're checking pulses, because that's very important. If they're awake, you want to see if they can squeeze your hands, if they can move their arms, if they can bend their knees. That's quickly will tell you, like, peripherally their neuro exam is good. And then if you're concerned about things, you get X-rays on these extremities. Musculoskeletal system, some pitfalls. There is potential for blood loss. Like if you have an open fracture that's bleeding, you have to get control of that fracture by packing, wrapping this extremity, because don't underestimate the blood loss from these extremities. So if somebody's just bleeding onto the floor, it's something simple can end up having significant impact. And then, you want a complete exam. You don't want to miss fractures. sometimes during the initial evaluation, uh, you don't catch everything. So that's where reevaluation later comes to play. And that's like what we would call the tertiary exam. This isn't something you would do initially. Let's say this patient had some major injuries. Sometimes that'll mask like a simple thing like a finger, hand fracture, or ankle fracture. Those should be ideally caught later on in the care of the patient by they're saying, my ankle is hurting a lot today. So then you examine it, and you kind of catch things that may have not been caught during the initial, rush of everything. Remember that even if there's no bony injuries, they could have soft tissue injuries that could be significant. There could also be ligamentous injuries. So if somebody's knee looked like it was bruised when they came in, you got X-rays of the knee, and the bone didn't feel like it was broken, and it didn't look like it was broken on the X-ray. But let's say when that patient gets up, they're in severe pain and they can't walk. You got to think about other things like ligamentous injuries. So the other thing to keep in mind is compartment syndrome. So looking at the compartments of the arms, of the legs, if there's a significant muscular bleeding, for example, or even in some cases a vascular bleed, if the compartment is very taut, very tight, there can be compartment syndrome, and that can compromise the blood supply for that limb and be a cause for limb loss. So if you're like a calf or a thigh or an arm, and it's severe hematoma there, and it's very tight, you got to worry about compartment syndrome. That can be an emergency. When we talk about neurologic, we talked about the GCS, the Glasgow Coma Scale. I would recommend if you work at a hospital, to have that GCS chart. You can get it from Google. Just print it out and put it in your trauma bay. That's how we do it here. We have a big poster of it. That way, you can just look at it and calculate a GCS quickly. But like we said before, you look at the eyes, you do a pupil size reaction, you look for lateralizing signs, frequent reevaluation, and then preventing secondary brain injury. This is a concept for severe TBI. So if somebody has severe TBI, like a traumatic brain injury, you want to avoid secondary brain injury. So that's basically injury to the brain that happens after the initial insult. So the main things that cause secondary brain injury is going to be hypotension and hypoxia. So one of the core tenets of management for traumatic brain injury is avoiding hypotension by giving blood products, by giving crystalloid, by resuscitation, by giving pressors. You want to avoid hypotension because that hypotension will lead to more brain tissue becoming ischemic or dying. And you want to avoid hypoxia because if the brain's not getting enough oxygen, it's not going to do well either. So if they're not securing if their airway's not secured, you want to secure it. You want to make sure they're on a ventilator, they're getting adequate oxygen. You have to avoid these two things, hypotension and hypoxia, because the literature is very clear that even one episode of either of them can affect outcomes. So if you're suspecting a severe TBI, you really have to uh, keep an eye on those two things to prevent secondary brain injury. If you're suspecting a severe TBI, you want to get neurosurgery on early so that they can come and evaluate the patient. If someone has a laceration, their GCS is 15, their neuro exam stable, they don't need neurosurgery right away. You can image them, get a head CT. If it's negative, then you don't need neurosurgery. The exam and your imaging are kind of key to clearing that. Part of the neurologic assessment is the whole spine. So let's say you've done the head, you've done a neuro exam, you've examined the chest and the abdomen, the extremities. The next thing to do is have the patient log rolled. So with your team, you roll the patient to look at their back. And then you want to examine the whole spine. So you just quickly palpate and ask them if they're in pain. And then you're looking for any step offs, so any like abnormality of the spine. Let's say they're unconscious and you can't. Uh, let's say they're unconscious and you can't get a good exam. Just feel for step offs, like feel for any ridge that says the spine is not in alignment. Reflexes, you don't have to do full reflexes on these exams, but just if they're awake, you want to get a full, quick motor and sensory exam. Can they move everything? Can they feel everything? Can they wiggle their toes? Just a quick assessment. Of course, if they're intubated, you may not be able to do this, right? Somebody asked about the GCS, so let me uh, quickly show you what I'm talking about. We have some time, so bear with me 1 second. Can you guys see this? You still seeing? All right, so the GCS, the Glasgow Coma Scale, it's three components. It's the eye, verbal, and motor. Okay, so
Dr. Amer,
basically,
Dr.
yeah,
Amer, I'm sorry, but you have to share the whole screen. The secondary survey only that's appearing on the screen.
I guess. All right, is that better?
No, yes,
Got it?
yes,
Okay.
amazing. Yes.
So just to kind of reiterate the GCS, we talked about this last week, but I'll re-explain it. But there's three components: eye, verbal, and motor. So eye, are they opening their eye spontaneously? Are they opening it to verbal command, or are they opening their eye to pain, or are they not opening their eye at all? So based on that, they get a score of 4, 3, 2, 1. Verbal is, are they talking? If they're talking to you, are they oriented? Are they making sense? Or are they confused? That would give them a 4. If they're just saying inappropriate responses, like the words don't make sense, but they're words, they get a 3. If they're just mumbling or groaning, they're not saying anything, that's a 2. And then if they're not saying anything, that's a 1. So the lowest, if you notice, 1 is the lowest you can get on each one. And then motor response, let's say, are they obeying commands? So you tell them, give me a thumbs up. Are they giving you a thumbs up? Two fingers, two fingers. Or are they only moving to painful stimuli? So let's say like you pinch them here and they reach for your hand. That would be purposeful movement to painful stimuli. That gives them 5 points. Withdraw to pain would be like you pinch their hand and they go like this. They just pull their arm away from you. That would be withdrawal. And then these are the abnormal posturing. So flexion, if you elicit some pain and they have a flexion response, or if you elicit pain and they have a decerebrate response, that's extensor response. So extensor is worse. That's a 2. Nothing would be a 1. So the worst exam you can have a GCS would be a GCS of 3. The best exam you can have is a GCS of 15. So you like this is what I was saying. If you're not familiar with this and you work in an ER, I would print this out or like find it on Google and just put it in the trauma bay, put it somewhere on the wall that you can quickly use it. I use this every day in the ER. I use it in the ICU. So you want to just have this away. It's a quick, objective method to assess somebody's neurologic status. So, like a severe injury would be like less than 9 on the GCS, would be like a severe traumatic brain injury. Moderate would be more like 9 to 12, and then mild would be like 13 to 15 GCS. If somebody comes in a GCS of 3 and they stay GCS of 3, you know, with your, even though you resuscitated them, that's a very bad prognosis. But if somebody came in like GCS 13, they became a 9 or an 8, that's the patient that may have a bleed or something that you can actually do about to help them. So you know um uh you want to just keep an eye on that. So that's the GCS. We'll go I'll go back to the other slide. You guys see this? All right, can everyone see this right now?
Yes.
Yes.
All right, perfect. Okay, so we talked about the whole spine, quick motor sensory exam, uh, reflexes. Again, you don't have to do the reflexes, but you can. and then figuring out imaging studies that you're going to need. A lot of times when it comes to the spine, you just want to get CT scans. If you have access to CT, you would just want to do that because a CT scan will quickly just tell you everything you need to know inside the chest and the abdomen and the spine. Just quickly will get your answers. It's not going to miss small things as well. So if you have a CT scan, you want to use it. And then if you're suspecting that somebody has neurologic deficits, let's say they can't move their legs, then you really need to worry about a spinal cord injury, and you need to get the neurosurgery team or the orthopedic spine team on quickly, because any neuro deficit should get a neurosurgical or ortho spine or whatever your institution has, should get a quick evaluation by them. After you're done with your initial management evaluation, then they can examine and take over the patient. You don't want to delay the whole assessment by having different consultants come in and do things. So this is just think about it. Once you're done with your exam, you want to make phone calls to, you don't want to delay definitive care. So some things to keep out is incomplete immobilization. You know, obviously, if somebody has an unstable fracture and you're moving them and bending their back, that's very bad. And then, like I kind of hinted at with the GCS, if somebody comes and their neuro exam is one thing and then it gets worse, you want to pick up on that quickly and you want to act on that quickly so you're not delaying any potential life-saving procedures. So special diagnostic test, basically, in most cases, this is a CT scanner. Yeah, in the real world, this can happen very fast. So if somebody comes in, and let's say even if they need a central line and they need blood, and I need to resuscitate them to get them stable, and then they get stable, a lot of times this can happen in 30 to 40 minutes, like very quickly. We can get the primary, secondary survey done. We can get central line access. We can start blood transfusions. We can reevaluate, get them stable. Like 30 minutes, they're stable. If your CT scanner is close by, then you can quickly get a CT scanner if they're stable and get a lot of answers. You should only do that though if the patient's going to stay with you. If you have surgeons, you have subspecialties, they're going to stay in this hospital, then you think about going to the CT scanner so that you can get some answers. But let's say that you're in a field hospital, CT scan, let's say, is very far away, it takes a lot of time to get a CT scan, and the patient's stable for transfer to go to a hospital. Don't delay that transfer. Just let them go. Just make sure that all your primary, secondary survey looks good, and then let the patient go. So again, you want to make sure that anything that could be major that will cause an issue is addressed, right? Let's say they have a big femur laceration, femur fracture, open fracture. If you don't, let's say, put a tourniquet on that femur, they can bleed to death on transfer if it starts to bleed. Sometimes what can happen is somebody may have like an open fracture, let's say, for example, an open femur fracture. And let's say their pressures were soft, like they're on the lower side, the blood pressure. Sometimes the vasculature can spasm and they won't bleed a lot. So you look at the wound and you say, oh, this isn't bleeding, we're okay. Then once you get their pressure better, and their blood pressure goes up a little bit, those vasculature opens up and they start bleeding significantly. So just keep that in mind, like something you really have to have a high index of suspicion of things that may cause a problem. Let's say they have a hematoma in the neck that you were watching, but it's they're kind of muffled their airway, but you're like, oh, it's fine. If they lose their airway during transfer, that's a catastrophe. So if you have a high index of suspicion of an airway problem, maybe you should intubate the patient before they go transfer, because the transfer process, you don't have control over it, and it's very difficult to provide care during that transfer. So just some things to think about. Also, poor communication. Like if you're taking the patient from one area to another hospital, let's say, or one area of the hospital to another area of the hospital, you want to make sure you're communicating with the next team that's going to take over the patient so they know what's going on. They know what you were thinking about. They know what you were worried about so that there's no miscommunication or poor communication. Like they didn't know you were worried about a spinal cord injury, for example. So just make sure you communicate with the people that are going to take over care of the patient as best as you can. Again, we talked a lot about this, but for like missed injuries, high index of suspicion. So a very high severe mechanism, you have to think about basically anything can be broken, anything can be, going on. Like let's say somebody fell from a great distance. Let's say they fell 3 stories. You may only see leg fractures, ankle fractures, femur fracture, but some mechanism that severe, you have to think about spine fractures too. So you have to have a high index of suspicion. If the mechanism is high enough, these are patients you're probably going to get more CT scans on. You're going to pan CT them, like I said, because you don't want to miss anything, especially if that patient's unconscious, they're not, really awake. And then again, like I mentioned, frequent reevaluation. So go back later, have someone from the care team go back, check on the patient again, see if anything else is bothering them, see if anything's changed in the exam. Pain management is another thing. If you have access to pain medicine, control their pain, because that can affect your vital signs. It can affect sensor, how the patient's doing. But obviously, careful monitoring is essential. And then we talked about transfer, just to kind of reiterate. So let's say you're you have to know what the capabilities of your institution are. So if you don't have a neurosurgeon and you're worried about a head injury or you're worried about a spine injury, you want to begin the process to get that patient to the right place. So you have to know what your institution is capable of. You have to know the process by which you transfer patients, because if you get a patient that needs to go somewhere else, you want to be able to do it in a quick fashion so that you're not delaying their care. And then when should the transfer occur? Once you've gotten airway and vent control, and you've gotten hemorrhage control, and they're stable, and there's no ongoing bleeding or no ongoing airway issues, then they can go. The main thing is the things that are going to kill the patient right away is going to be airway problem, breathing problem, like a pneumothorax, hemorrhage, which is going to be bleeding. So you need to control those 3 things. And if those are stable, then the patient can go. I talked about this, just kind of knowing what your, resources are and what the process is. And that's basically everything. We can do a case if you guys want. Does anybody want to talk through a case and I can give you information and you kind of tell me how you would walk through it? All right, so I can just do the case and kind of walk you guys through it. But so let's say you have a 44-year-old male driver. He crashed into a wall. The patient's found unresponsive at the scene. They bring him to the hospital. He has a C-collar. He's on a backboard, and they're giving him bag mask ventilation. So the first thing you're worried about with this patient is their airway, right? Because they're bag masking them, and he's unresponsive. So if he's unresponsive, he's unconscious, he may not be protecting his airway. So the primary survey, the first thing is the airway. So if he's not protecting his airway, I'm going to want to intubate this patient quickly and get him intubated. As part of the intubation, so like if he has no neurologic exam, you may not need intubation medications like etomidate and succinylcholine. But if he is moving, then you're going to want to get IV access and you want to get this rapid sequence intubation medications in so you can intubate the patient. So the IV access is kind of part of C, right? So you get access, you have someone listen to their breath sounds, that's B. You get IV access, you give them the medications, you get them intubated, then you calculate a neuro exam, expose the patient. So unresponsive, getting bag mask ventilation, I'm worried about his airway. He's not protecting his airway. So the number one thing here is getting their airway secured. And then once the airway secured, start your primary survey from the top. So airway secured, you check your ET tube, the cuff is up, it's working. You check where it is at the teeth, like it's at, let's say, 24 centimeters at the teeth, so you know where it is. Then you listen to the breath sounds, make sure they're moving air and the bag masking is, or the bag ventilations are working properly. Then you check, you go to C, make sure you have IV access, check their pulses, get a blood pressure, get them on the monitor. If there's any hemorrhage, you know, you control the hemorrhage. Disability, if you just gave them medications to intubate them, you may not be able to get a GCS, but you can kind of quickly, you know, get what you can from it and expose the patient, keep them warm. And then if ever, you know, if your blood pressure is fine, your vitals are fine, your primary survey looks fine, now you go on to the adjuncts, right? So you get a fast exam, you get a chest x-ray, then you move on to have someone do a secondary survey, which is the head-to-toe examination. And then you decide where you're going to go with this patient. Are you going to go to CT scanner, or are you worried about a bad traumatic brain injury and you need to transfer them? Whatever you need to do, that's, you know, the next step. So I'll just show you back here. Go all the way to the top. So again, just to recap, this is kind of the global concept of the initial assessment, preparation, the primary survey, which is A, B, C, D, E, resuscitating the patient, the adjuncts to the primary survey, which is like a chest x-ray, pelvis x-ray, EKG, Foley, fast exam, all that falls under adjuncts. Reevaluation before you move on to detailed secondary survey, which we talked about today, which is a head-to-toe examination. You know, you reevaluate the patient again, just kind of very quickly. Your adjuncts is going to be like going to CT scanner, having consultants see the patient, and then reevaluation and definitive care. Does this patient need to go to the OR? Do they need to go to the ICU? Do they need to go to interventional radiology, let's say, for angio? Or do they need to be transferred to a different hospital? So this is kind of the global bird's eye view of everything. And I think that covers all of it. Anybody have any questions?
Jazakallah khair, Dr. Amer. That was so helpful. And I'm sure that everyone really found it very useful. If there are any questions, people can message me and I can forward them on to you, and then maybe you could answer them in that case if no one wants to, or someone can't think of anything right now. But Jazakallah khair for all your time. It was really lovely to hear from you about the ATLS.
All
Jazakallah
right.
khair.
Thank you, everyone. Ma salama. Thanks for having me.